So we know that the average time for symptom resolution after someone is put on antipsychotic medications for hallucinations specifically is about a month. So I'd really be questioning someone who reports full resolution after either a single dose or two of medications or something that we see on the inpatient side, simply by being transferred from the emergency department to the inpatient unit, causes a miraculous recovery of symptoms without the initiation of medications. Um, and after about a month of being on medications, patients typically report that the voices will become less intense or maybe less distressing. And then they report ongoing improvement over the next 6 months or so, not an overnight event. Patients often perceive the voices to be omnipotent, omniscient, and malevolent. When the voice is perceived as malevolent, the voices often serve to evoke, distress from the patient, which is often met with either arguing or shouting or maybe refusing to comply with what the voice is saying or asking. They may do things to avoid things that they've identified as triggers that bring on the voices. Conversely, when the voice is perceived as benevolent, the tone and the words are going to be, more kind, maybe more protective, and they're going to serve to evoke more positive emotional state in the patient. Which might be met with elective listening, willing compliance, or maybe even acting in such a way as to bring on the voices more readily. And then lastly, atypical features, which we're going to discuss further. Those are infrequently reported, as low as less than 5% of the time. Okay. So most persons with genuine auditory hallucinations report that they are worried or upset by their hallucinations. The major themes of auditory hallucinations in schizophrenia are usually going to be persecutory or instructive in nature. And auditory hallucinations in schizophrenia tend to consist more of, personal insults, abuse or abusive language, derogatory comments about the patient or the activities of other people. In a clinical population, auditory hallucinations were associated with significant distress and negative emotional content. And such voices are less likely to be faked because they're unflattering. And on the legal side of things, they really fail to exculpate criminal defendants. So why would they, claim that that is the variety of their voices? About a third of persons with auditory hallucinations reported that the voices asked them questions. For example, why are you drinking? Or why didn't you call your wife? Genuine hallucinated questions tend to be more chastising rather than like seeking information. Additionally, if the hallucination is command in nature and the patient does not comply with it, this may result in the question being repeated, shouted, or in further chastising for failure to comply. Many individuals they may engage in an internal dialogue with the hallucination, with some going so far as, to cope with chronic hallucinations by incorporating them into their daily life. 98% of individuals with auditory hallucinations, pretty much an overwhelming majority, report negative impact on their life. And only about 50% report some type of positive impact or benefit from their auditory hallucinations. A majority also report improvement when they're distracted or they're engaged in activities. So many report coping in exactly that way. And knowing that, it shouldn't be surprising that about 80% of patients report that these experiences are worse when they're alone and better when they're not. And lastly, patients experiencing auditory hallucinations report a wide range of intensity, from whispering to just kind of a normal speaking voice, all the way to shouting, screaming, yelling. Okay. Talk a little more specifically about command auditory hallucinations. When we study individuals who report command auditory hallucinations, some of the data is a mixed bag. Specifically with regard to whether or not patients comply or act on the commands. Some of the available data suggests that 76% of patients report often being able to resist compliance with the voice. Other studies looking at patients' compliance or resistance in the last 30 days show a compliance rate of about 84%. So again, mixed bag. But the big takeaway from this is that while genuine auditory hallucinations can and do often result in a response, I would be wary if I was interviewing someone who said that they had absolutely no ability to resist or to not comply with the command that a voice had given them. And similarly, we know that genuine psychotic patients report a mix of command and non-command auditory hallucinations. So again, I'd be kind of wary as well of someone who reports that all of their auditory hallucinations were command in nature. That would make me kind of skeptical. So what makes a voice more likely to be listened to? So when we ask patients about that, they report that some voices are harder to resist, or they feel that they have to comply with. And the factors that they seem to have in common is, if they're familiar with the voice, or if, there is a hallucination-related delusional belief that is also factoring into the equation, or that they perceive the voice to be very powerful. And then we do see compliance go down when the action that is commanded is perceived as really dangerous by the patient. Okay. When we ask about the content of commands, we do see some variety. So 52% report that the voices are telling them to kill themselves, while only 5% report that the voice is instructing them to kill others. And if we were to believe every murderer who claimed after the fact that they'd killed their victims because a command auditory hallucination had told them to do it, we'd expect that number to be quite a bit higher. And it's not. 12% report being commanded to harm but not kill themselves or others. 14% report being instructed to engage in some other kind of nonviolent action. And then 17% of the participants did not specify the command that they were hearing. One thing to note on this study specifically was that it was completed retrospectively and done by chart review. And as clinicians, we're always just a little bit more diligent when we document potential violence. And so some of these statistics with regard to the suicide numbers, they might be a little overrepresented, maybe a little bit skewed. And something to consider, and we'll look at this a little bit more in a bit, is that an auditory hallucination is unlikely, or at least a little less likely, to produce some kind of action if it's not linked to a delusional belief. And it's typically going to be a belief about the voice specifically. For example, like maybe the voice is very powerful, or the voice has the means to kill them or harm their family if they don't comply. And lastly, another point of caution would be a patient reporting command auditory hallucinations absent any other signs or symptoms of psychosis. I'd be really cautious in that situation with the diagnosis. So, how are patients who experience auditory hallucinations coping? We talked about a statistic a little bit earlier. About 66% of patients reported that they'd come up with ways to manage their voices. 69% reported some success in that area. Using one or more varieties of coping strategies. These numbers are typically much lower in malingered cases. You don't need to figure out how to cope with something that's distressing if you're making the whole thing up. But it's also likely because of this perception that being absolutely unable to control the issue, that sounds worse. It makes you sound more sick. It makes you sound crazier. So that might be factor into the equation of why we don't see it as much. Some of the reported coping strategies that patients talk about include engaging in activities like watching TV or working on a project or maybe socializing. Something as simple as a change in posture or environment, going from seated to standing, going inside to outside. Maybe they seek out some sort of interpersonal contact. My personal favorite is when the coping mechanism is to take their medications. That is definitely my favorite. Or maybe engaging in prayer, something spiritual that is important to them that maybe grounds them or distracts them. All right. So we spent the last while talking about typical, genuine, psychotically driven auditory hallucinations. So I want to pivot to reports from patients that should leave you feeling a little bit skeptical, or at least put you kind of on this path towards further investigation of what you're hearing. So here you see a list of reports that would be kind of atypical in patients who have genuine auditory hallucinations. Bearing in mind that earlier statistic that some genuinely ill patients, less than 5% though, may occasionally report atypical symptoms. So this isn't like a list that should be viewed as like, oh, this person is 100% malingering. Again, it should kind of prompt you to inquire and investigate further, run it down. So if you're interviewing someone and they report that their auditory hallucinations are always unbearably distressing, if the voice sounds mechanical or robotic, or it sounds like animal noises, if they report that the voices come from inside parts of their body other than their head, if the voice refers to them by a title such as Mr. or Ms., if the voice changes gender mid-sentence, if they report never hearing the same voice twice, if they report that the voice only yells, if the voice is always vague, inaudible, or mumbling, if they report only ever hearing the voice of a woman or the voice of a child, again, if they allege that they only hear commands or that all commands have to be or are immediately obeyed, if they report hallucinations that aren't associated with a linked delusion, a patient who's failed to come up with a single coping strategy, despite reporting distressing, malevolent voices, that would be kind of surprising. A patient who reports only hearing verbal auditory hallucinations. In reality, it's more likely to be a variety of things. They may hear verbal, they may hear music, clicks, or bangs, and they may experience hallucinations in other sensory modalities as well. If you have a patient who denies that being alone worsens their symptoms, I'd be a little skeptical. If they report voices asking questions that are seeking information versus chastising. For example, the voice asking, hey, what time is it? Versus, why are you smoking? Why are you doing that? They report the voice is never affected by their current context, like their mood or their location, or maybe the presence of other people. They reported the voice communicating in stilted language, for example, go commit a sex offense. If they are unable to recall the first time that they heard voices, we touched upon that a little bit earlier. And lastly, that you see kind of no evidence of distraction or internal preoccupation while you are with them, or other staff don't observe that. It's hard to say, I'm hearing voices 24 hours a day. I'm hearing them while you're talking to me. But at the same time, I don't appear to be distracted. I appear able to completely attend to the conversation that we're having. That would be pretty unusual. All right. Shift sensory modalities, talk a little bit about visual hallucinations. We see these less in individuals with psychotic illness. They're typically more common when substances are on board. And the report's pretty variable, ranging anywhere from 24 to 54%, depending on which study that you look at. So we can start by looking at features associated with kind of more typical visual hallucinations, and then we'll talk a little bit more about atypical presentations. So a majority of the patients report that the vision that they see is humanoid, and an overwhelming majority reporting that it was either something or someone that they had never seen before. And when it is humanoid, they're normal sized. More than 80% report that their first experience caused them distress, fear, overwhelm. A natural response to seeing something unpleasant or scary may be to shut your eyes. However, this typically has no impact on psychotic visual hallucinations, which is different from the visions that might be reported by someone who's experiencing visual hallucinations related to substance use.
I have a question.
Yeah, go for it.
When it comes to like the humanoid type visual hallucinations, I think Dr. Jacobs knew I was going to ask this. Do some people report seeing like a shadowy type figure, or even like not necessarily like human, but like a almost like a bent over creature?
Um,
Have you heard that?
shadowy creatures are not uncommon. So I would not necessarily kind of cast aspersion on that. Specifically something that is bent over, I would maybe just want more information. Um, like why is it bent over? Is it doing something? Is it participating in some kind of activity?
It's,
I would probably inquire a little bit further, but shadowy figures, very common.
I would say it's like when you're thinking like bent over, it's like almost not like it doesn't like not looking like an elderly person, but like kind of
Mhm.
like bent over in that way, but more eerie, like really like more creaturey type.
Yeah.
Yeah.
Yeah, I mean, I think I would probably continue to inquire, like, does it have human facial features? Kind of get a little bit more information on the actual kind of description of the features that they can identify or they can make out for sure.
Thank you.
Yeah. All right. Um, So things that would be considered atypical with regard to visual hallucinations would be visions that someone reports are only ever in black and white rather than color. Typically, it's going to be a mixture of the two. Someone who reports just really kind of dramatic visions. Um, Someone who reports a change when their eyes are open or closed. We kind of talked about that on the last slide. Um, I would be skeptical of a diagnosis made of schizophrenia with only a report of visual hallucinations, because that would be pretty atypical. Um, Seeing figures that are either miniature or giant sized, that is definitely more typical in visual hallucinations that are induced by toxins or alcohol or other organic brain disorders, but they would be atypical in a psychotically driven visual hallucination. So definitely still on the list, but it would change your differential. Um, and lastly, visions will often be tied to auditory hallucinations and associated delusional beliefs. So absent those connections, I would probably be a little bit skeptical. Okay. So there are some distinctive hallucinations that are reported, for example, with certain substances or with certain medical conditions. These are often unrelated to psychosis and may appear atypical by the standards that we've already been discussing tonight, but they're no less real and no less in need of investigation and treatment. So I discuss them here mostly to hopefully prevent someone from experiencing this type of hallucination from being labeled as a malingerer, simply because their experience doesn't kind of fit the mold that we're talking about, that we see in textbooks, and things like that. So we can start with the psychosis that's often seen in individuals who are drinking alcohol. An alcohol-induced psychotic disorder is the presence of delusions or hallucinations resulting from intoxication and or withdrawal from alcohol. The symptoms often resolve with or without treatment, typically within days to weeks after the person ceases drinking alcohol. Um, when we compare it to schizophrenia patients, we see some pretty major differences in the overall presentation. These patients typically have more depression or anxiety symptoms and fewer disorganization or disorganized symptoms. They have better insight and judgment and typically less functional impairment. The auditory hallucinations are going to predominate similarly to schizophrenia, but they're more likely to be manifested as music, noise, or unintelligible sounds. And patients may discuss these symptoms more readily. And lastly, these experiences are, typically frightening to the patient each time. They have very little time to acclimate or develop coping strategies before the symptoms resolve and they're gone. So it's a little bit different from our chronic psychosis patients who they're dealing with this day in and day out, and they're kind of forced out of necessity to figure out what the heck to do to try to make their lives a little bit more bearable. We don't see that in this population. And the risk of developing alcohol-induced psychotic disorder is going to be higher in individuals who are younger when they developed their alcohol dependence, those with a family history of alcohol problems, and in individuals with multiple episodes or multiple hospitalizations that have complete inter-episode recovery. And the voices that these folks hear are often described as accusing, threatening, or insulting. Um, but major themes include spirituality, persecution, maybe being given instructions about management of kind of everyday life, everyday affairs. Okay. Um, there are some general medical conditions, largely neurological in nature, that can result in hallucinations. In these cases, visual hallucinations are more common than auditory. Lower prevalence of other psychotic symptoms, things like disordered thoughts or bizarre behavior, or negative symptoms. And these folks often present with pretty complex visual hallucinations, especially in cases of seizure disorders or brainstem lesions, or maybe even issues with the visual pathway in the central nervous system itself. Tactile hallucinations were more common in substance use, specifically most commonly reported with cocaine. These people will feel kind of cutaneous or subcutaneous irritation that can lead to them scratching themselves so badly that they may bleed, they may scar. They typically don't endorse any other psychotic symptoms, with the exception of when they're acutely intoxicated. All right. So our last slide on hallucinations, talk briefly about olfactory hallucinations. So 13 to 17% of patients with schizophrenia report olfactory hallucinations and report that they frequently occur with hallucinations of taste, touch, maybe other bodily sensations. It's typically going to be an unpleasant odor. I'd be pretty skeptical if they report that it's really pleasant or they like it or it's floral or it smells like a food that they love to eat or something like that. And these are, again, more commonly associated with general medical conditions, things like epilepsy or cerebral ischemia, but they can occur in patients with schizophrenia, typically going to be an older age group of patient. And these patients will often have a hard time discerning if the sense stimulus is real or imagined. All right. So we're going to move on from hallucinations, discuss another salient feature of the psychotic presentation when we talk about delusions. Firm fixed beliefs. They stand up to challenges or evidence to the contrary when that's provided. They typically involve, one or more themes, things like disease or contamination, grandiosity, jealousy, love, persecution, religion, being possessed. I see a lot of delusional pregnancies or pseudocyesis on my unit. I've had at least 10 patients in the last 2 years divulge to me that they are married to Taylor Swift. I don't think that that's true. I have a patient right now on my team who's reluctantly accepting medications that I'm giving him, but is quite frank with me in my daily interviews that what he really needs to cure him is an exorcism, and not his risperidone or lithium. 66% of manic patients versus about 50% of schizophrenia patients report grandiose delusions. Things like being the CEO of a Fortune 500 company, being a highly influential political figure. Persecutory delusions are perceived as kind of the most threatening and also the most enduring. And for our purposes in mental health, usually the delusions that are more likely to have a patient act on them. The complexity of the delusional belief system can be a reflection of the individual's level of intelligence. And another common theme in more recent years has been delusions that are based in technology, beliefs about satellites or cell phones or implanted microchips, for example. And these are going to occur overwhelmingly more so in men than women at a ratio of about 7 to 1. And while I've seen a bunch of these cases, probably the most alarming one that I've cared for clinically was actually a female patient. She believed that the government had placed microchips behind her eyes, and she was brought in initially as a trauma patient after she had actually attempted to remove both of her eyes to try to get the microchips out. So that was a pretty alarming, dramatic presentation. Okay. So, earlier we had mentioned, substantial resolution of hallucinations within about a month of treatment. But for delusions, if you're going to get them to go away, it's a lot longer. Often delusions are resistant to medication treatment and therapy. But if we're going to see improvement, the medium time frame is closer to 2.5 months. And the typical pattern that we see is that the belief becomes less and less relevant to the patient, and ultimately they kind of relinquish the importance of the belief. Now, on my clinical service, I don't really have the luxury in an acute inpatient setting to hold people until their delusions resolve entirely, if they're even going to. I'm typically looking for a patient to kind of relinquish the importance of the belief to them, and from a safety perspective, deny a desire to act on the belief in such a way that makes them dangerous to themselves or other people. Because the idea of keeping folks hospitalized on an acute inpatient setting for an average of 73 days is never going to happen. So we kind of have to be judicious in our safety assessments and figure out when is a good time to let people head back into the world. Okay. So similarly to our discussion on hallucinations, there are some typical and atypical features that we see with delusions as well. So genuine or typical delusions often going to take weeks or months to develop or to disappear, whereas an atypical presentation would involve kind of the abrupt onset or abrupt resolution of that belief. Behavior will usually conform to the content of the delusion versus not. As a delusion is a psychotic process, it's likely that you'll see the presence of other psychotic symptoms as well, like disorganized speech or disorganized thoughts. Observe the patient for either, a reluctance or an eagerness to discuss the content of their delusional beliefs. In instances where someone's experiencing a persecutory delusion, it makes sense that they become paranoid and that their day-to-day functioning will be impacted. The higher the emotional commitment to the delusion, the more likely they are to show poor function, and the more likely they are to get hospitalized. And there's really no such correlation in suspect or atypical delusions. In fact, you should probably be skeptical of someone who seems to be highly convicted of this delusional belief and reports no impact on their day-to-day function or their day-to-day behaviors. A case that I worked on a number of years ago involved a middle-aged gentleman who had actually stabbed his own teenage son. Throughout the course of his stay with us in the forensic hospital, we discovered that he had a fairly extensive delusional belief system, but the crux of it was he believes that his neighbor from across the street had been entering his home, going into his refrigerator and his cabinets, and poisoning his food. And he believed that this had been going on for months. On the day of the stabbing, he reported hearing a voice telling him that today was the day that the neighbor was actually going to enter his home and kill him. And he reported having heard similar voices before, and this had actually prompted him to hide weapons all over his house so that he'd be ready to protect himself when and if the day came. And so his very unsuspecting teenage son entered the home unannounced. I think they had a plan to, go get haircuts. So the son had come over from his mom's house to meet with dad, and they were going to leave the house together and go get these haircuts. And the teenage son comes into the house, he comes in unannounced, and believing that it was the neighbor, this gentleman stabbed his son. And during the investigation and evaluation process, I got tons and tons and tons of crime scene photos, which objectively supported pretty much all of this guy's report. His refrigerator and cabinets had been chained and padlocked shut, presumably to keep the neighbor out of them from poisoning his food. And I had a lot of photos of tons of knives and I think at least two firearms hidden throughout the home, like in an umbrella stand, behind couch cushions, taped under coffee tables, things like that. All right. So another symptom that we sometimes see alongside serious mental illness is going to be mutism. And similarly to the symptoms that we've already talked about, mutism can be real or it can be feigned. And so I always like to kind of talk about this with a little historic anecdote. Um, if you've ever heard the expression of being pressed for an answer, so that expression comes from hundreds of years ago. And criminals would be brought before the court and asked to plead guilty or not guilty to a crime. And the people who refused to answer or refused to enter a plea would basically be laid down on the ground and subjected to having rocks piled on top of them. And that would determine, if they were quote unquote visited by God, aka genuinely unable to communicate, or if they were being obstinately mute. And the end result of the rocks is that either the person eventually gave up and spoke, proving that they had been faking it all along, or for the actual mute people, they would die under the weight of the rocks, and the court would have its answer, for better or for worse. Um, and so, we see mutism pop up in a few psychiatric settings, things like catatonia, or in schizophrenic patients who have pretty extreme paranoia or distrust. We can also see it induced by certain medications that are like steroids and blood pressure medications that can cause it as a side effect. I see that in literature. I have not seen that in clinical practice. In cases of suspected catatonia, though, mutism alone would be pretty unusual. So we would also be looking out for some of the other signs and symptoms of catatonia. Okay. So, things to keep in mind are that malingered mutism or malingered catatonia, that would be pretty gosh darn exhausting to simulate for longer periods of time. And for this reason, maybe it's sometimes best to observe and ultimately make the malingering diagnosis in the inpatient setting. Eyes are on them all of the time, having to sustain that ruse for longer and longer periods of time, nowhere to really hide, can't take a break. It would be difficult. Further investigation would involve comprehensive evaluation, including a neurological exam, repeated interviews, observing the patient at unexpected times, such as via, like closed circuit cameras located throughout the unit or like in day rooms and things like that, where they might be think they're not being watched and they may take the opportunity to socialize with their peers. Collateral reports from nursing or other staff members. One trick that I've used personally is waking the patient up from a pretty deep sleep with a really basic question. So again, this person hasn't spoken to me or demonstrated speech since the time that they've been admitted. I have a strong suspicion that they are full of it. I'll wake them up out of kind of a dead sleep and be like, "Hey, are you Mr. Smith?" And seeing if they reflexively respond to that question. All right. So the last psychosis-associated symptom that's kind of often feigned and that I wanted to touch on before we move on is malingered cognitive deficits. And this is a thing because many malingers believe that feigning cognitive deficits in addition to psychotic symptoms will ultimately make them more believable. And while they might not be 100% wrong, the issue is that they often just take it way too far. They'll give incorrect responses to, patently easy or obvious questions that even genuinely cognitively impaired patients would probably get correct. Some malingerers believe that they have to demonstrate memory impairment to look more realistic or more believable. But again, they either go too far, often claiming kind of a level of memory impairment that is just beyond the pale, and certainly far worse than the memory loss we'd expect to see with folks, even in cases of kind of genuine dementia, or they just get it wrong altogether. They'll claim that long-term memory is more impaired than short-term memory, which would be an atypical pattern for memory loss. Or they'll claim to have more trouble with recognition memory versus recall memory, which again would be atypical in a patient with genuine memory loss for any reason. Um, Overall, they may give more evasive answers to questions about cognition. They might repeat questions either to kind of give themselves time to think or to make themselves appear more impaired than they really are. Um, they may give kind of vague or even hedging responses to pretty straightforward questions. So Mr. Smith, you say you're hearing a voice. Is the voice that of a man or a woman? Oh, well, it was probably a man's voice. And kind of these hedging, non-definitive answers. Okay. These folks are more likely to respond with, I don't know, to questions about psychotic symptoms. And you're always welcome to take this at face value that they really don't know, because they've never actually experienced the thing that they just said that they experience unrelentingly. And also, while it might be easy to feign kind of a bogus delusion, aka a big fat lie, it's much, much harder to feign the form and process of psychotic thinking. It's hard to simulate things like derailment or neologisms or loose associations, word salad, tangentiality. It's not impossible, of course. There aren't any absolutes, especially with your more experienced malingerers or partial malingerers, which we'll talk about in a minute. But it's hard. And a malingerer is unlikely to be able to feign kind of the more subtle symptoms of psychosis, the stuff that frankly isn't portrayed well, accurately, or at all in the media or on TV or in movies, because that's where sometimes they're getting that stuff from. And that would be things like negative symptoms like the flat affect or the alogia or the abolition. Things like impaired relatedness or digressive speech, or even just kind of the peculiar style of thinking that schizophrenic patients demonstrate. Okay. So we talked about some pretty specific means of distinguishing typical from atypical type psychosis. So I wanted to provide a bit of a summary on the subject before we move on. So basically, some red flags that should set off your spidey sense in an interview and maybe push you towards a bit more investigation of the things that a patient is saying or doing. So if the patient in front of you is reporting solely subjective symptoms of psychosis, but you see no objective signs or even subtle signs, I would be curious about that presentation. Someone reporting to you that they hear voices 24/7, nonstop, always distressing, but can be seated across from you for an interview without appearing internally preoccupied or to be responding to internal stimuli should raise some red flags for you. Be on the lookout for inconsistencies and contradictions. This can be all from the patient in the course of one interview or maybe a series of interviews. This can be when you compare and contrast patient reports with collateral from outside sources like family or coworkers or law enforcement. Watch for improbable symptoms or patterns of symptoms. This can include overly dramatic presentations, mixed mood presentations, or the report of kind of extremely unusual symptoms. And that actually is the basis for some of the psychological testing that we can offer to rule in or out malingered psychosis, specifically the SIRS, which is my personal favorite of all the psychological tests. The SIRS test has a patient respond to whether or not they experience increasingly unusual and frankly gets to pretty gosh darn bizarre symptoms, and often symptoms that are not even really associated with psychosis. And if they just yes you to death on this test and they endorse a majority of these symptoms as they get increasingly bizarre, it's likely that there is feigning happening. So for example, one such question from the SIRS includes, do you believe that cars are a member of an organized religion? I don't know any genuinely psychotic people that believe that, but you are likely to get a malingerer to say, well, gosh, that sounds crazy as heck. So yes, absolutely. Those cars all worship the devil or whatever. Lastly, I would take a close look at how participative they are in the interview process. Truly psychotic individuals may participate less optimally because they're distracted by internal stimuli, or maybe they have some thought disorganization or thought blocking, or some other impairment on their ability to communicate. But a patient who appears purposefully evasive or uncooperative is concerning. That's very different. Do they seem excessively guarded or hesitant? Are they repeating questions over and over? And are they doing that to maybe buy themselves time to formulate the answer that they think that you want? Who knows? All right. So talking about partial malingered psychosis, um, patients with true schizophrenia might malinger additional symptoms. And sometimes they do this to avoid criminal responsibility. Maybe they're doing this to seek an increase in disability compensation. These cases can be pretty difficult. On one hand, they have a well-documented genuine illness, which lowers our index of suspicion. They can be fairly sophisticated malingerers since they probably have real life experiences to draw from, either their own or the experiences of other patients that they've been hospitalized with. And they can also be difficult because we have this tendency to dichotomize patients as being either mad or bad, which leaves little room for a person who may very well be both of those things. All right. So, talking a little bit about interview technique. And kind of what your approach should look like. What does that mean exactly? So we are going to, strive to be objective and try your hardest not to show that you're suspicious of their reports or suspicious of their behaviors. We're going to use open-ended questions that prompt the patient to deliver, more of a narrative response. Try to avoid leading questions that simply result in a patient saying yes or no to particular symptoms. And if you can, determine if the patient has had the opportunity to observe someone with genuine psychosis, and if so, who, how close, and for how long. Feel free to take your time, go long, or even better, have the individual observed in an inpatient setting. Remember, if this is a charade, that gets harder and harder to keep up as time wears on, or that level of observation is ramped up. Be on the lookout for rare or improbable symptoms, like we've discussed. In forensic settings, more than in clinical settings, there's some room to employ what I'd refer to as some shady tactics. Things along the lines of like catching someone off guard with a question, kind of like what I had mentioned earlier with the patient feigning mutism. Or a personal favorite would be mentioning a fake or highly improbable symptom within earshot of your suspected malingerer, and then follow up to see if they suddenly report that symptom. I said it's a little shady. A while back, I was actually in a position where I did assessments of psychiatric disability, specifically for PTSD on service members who were getting ready to leave active duty. So I'd review records and then I would conduct clinical interviews in person in my office. And I had this weird trend that developed. And on a few occasions, I had patients come to see me for the interview and they'd have a blanket with them, which I thought was really odd. Um, and so I was like, I asked them about it. I'm like, yeah, you brought a blanket to a doctor's office. I have questions. Why? And I had, the first patient that I asked about it tell me that it was their survivor's quilt. And I was pretty confused by that response. So I took to the internet to do some sleuthing. And apparently, I found a Reddit post, frankly, that directly tied this to an informational pamphlet on PTSD that had been printed by our local VA. And instead of discussing the very real symptom of survivor's guilt, a typo had suggested that individuals who are really suffering with PTSD have a survivor's quilt. And in an effort to appear really disabled when they came to see me, these patients got themselves a quilt to bring to their evaluations. I will never cease to be amazed by the magic of a typo. Lastly, one technique that you could try is a technique called set shifting. So that involves interspersing questions for detecting malingering within your history taking, or maybe kind of in periods of very informal conversation that aren't really targeted towards evaluation. And the shifting may cause the individual to kind of momentarily forget or abandon the fact that they were faken. And this strategy was actually used with Gigante, our friend from earlier, specifically with his attempts to feign severe dementia. Throughout the course of some of his evaluations, he had claimed that he was just completely disoriented with regard to time. And during a break in one of his examinations, he was asked kind of in this offhanded manner by someone whether or not he knew what time it was. And he very quickly, without hesitation, looked at his watch and responded with the correct time. And I went, gotcha, caught. All right. So throughout the course of your clinical interview, one of your goals is going to be to spot inconsistencies. And these inconsistencies can be internal or external. And by internal consistencies, I mean looking for, inconsistencies within the individual's own report or narrative. Maybe they discuss being constantly confused, but they discuss that in a clear, logical, and linear way. Maybe it's as simple as, giving alternative versions of their own history, either throughout, the course of one single evaluation or maybe across different interviews, either with you or with other people. Externally, we're looking for inconsistencies between the subject's reported symptoms and then what we observe, or what we know their current level of functioning to be, or what we know genuine symptoms to look like, or with the findings of psychological testing. So we look for inconsistencies in that way. Okay. So, something that comes up quite often by clinicians is a reluctance to label a patient as malingering. And it's not really a bad reluctance to have. We can talk about why that's a problem earlier. Literature shows that diagnosis of malingering can have some pretty serious impact on future provider bias and future patient care. But that said, if you feel that in the course of your assessment, either independently or with a care team, that you've kind of followed this algorithm or one that's kind of similar, you're probably safe and well within your rights as a clinician to identify someone as a malingerer. If you've identified that the individual has a clear external incentive to malinger, because that's kind of the crux of the diagnosis, if you've identified variability of the presentation, either between interview and non-interview behaviors, or maybe gross inconsistencies in reported symptoms, or even blatant contradictions within the medical record. If you've identified improbable symptoms, such as, atypical hallucinations or delusions, maybe a very convenient timing of symptom onset with criminal allegations, or elaborate symptoms that seem to lack ties to the normal themes that we see of paranoia, persecution, grandiosity, religion, or if you just flat out have confirmation of malingering, either in the form of admission, unlikely to happen, or strong corroborating data, either within the history, or maybe in the context as proof on psychometric testing. Okay. All right. Sorry. Take a sippy sip here. In a forensic setting, the most common times for an individual to feign symptoms of psychosis are going to be at some pivotal junctures within the criminal justice process. Namely when being assessed to be competent to stand trial, or being assessed for the viability of an insanity plea. So we'll start with some of the data that we have for individuals who try to feign incompetence to stand trial. For context, individuals who can successfully feign trial incompetence have a lot to gain. They may spend their pretrial time in a hospital instead of a jail. And in some cases, their charges may be dropped entirely. That's a pretty gosh darn big motivator. Um, in 2006, Warren reviewed roughly 8,500 competency to stand trial assessments. And of the evaluations that were reviewed, 19% of the cases, the evaluator opined that the individual was incompetent to stand trial. And a finding of incompetence was most strongly linked to individuals who had psychotic disorders, organic brain disorders, or intellectual disorders. And again, the motivation to malinger is high because if you are found non-restorable, you may never see the inside of a courtroom or the inside of a jail or the inside of a prison. And if you are restored, it may help pave the way for a future successful insanity acquittal. There was a 2013 study that found a rate of malingering nearing 20% in defendants who were hospitalized for competency restoration to be restored to competency to stand trial. Thankfully, if this is something that you're concerned about or you find yourself in a position doing these kinds of evaluations, there are some very specific psychometric instruments that we use to help clarify this diagnosis. One of them listed there is the Exter. There's another one called the McCatka or the MacArthur Criminal Adjudication Instrument. So we have testing geared towards identifying malingering very specific to trial incompetence. Okay. The motivation to malinger for the purposes of an insanity acquittal is also pretty substantial. Again, this can result in avoiding a courtroom and certainly avoiding prison because successful pleading of insanity means you go to a hospital instead of a prison. Malingerers are, more likely to have some kind of non-psychotic motivation for their crime. Things like revenge or jealousy or greed or anger. In a similar vein, genuinely psychotic explanations are pretty rare for maybe the crimes that they've committed, crimes like rape or robbery or fraud or forgery. In 2004, our friend Warren is back. Warren looks at 5,175 insanity evaluations. And in those evaluations, NGRI, or not guilty by reason of insanity, or not criminally responsible, was opined in about 12% of the cases that were reviewed. And opinions that supported insanity included a diagnosis of psychosis, some sort of organic illness, maybe a serious affective disorder, and a past history of psychiatric treatment, versus opinions that supported the individual being sane and criminally responsible were things like drug charges, the history of a diagnosis of a personality disorder, being intoxicated at the time of the offense, or maybe a history of prior criminal activity. So all those kind of pointed towards, you were more likely to be found sane versus insane. It can also help to determine the timeline of the malingering. For an insanity defense, you have to only prove that the individual was insane at the time of the offense. And so it matters far less if they're insane currently in front of you or weeks or months or years later. The only time hack that really matters is their mental state at the time of the offense. Okay. So, with regard to feigning psychosis for the purposes of an insanity acquittal, there are a few things that should make us suspect that the explanation is genuine. So I'd be skeptical if the current crime, maybe fits the same or a very similar pattern from previous criminal charges or activity. If the individual has a history of murder or rape charges, or maybe a diagnosis of antisocial personality disorder or sexual sadism, if the person has certain high subscores or total scores on the psychopathy checklist, which would be included kind of in any sound forensic assessment, as part of, an assessment, you should be seeking collateral information from the facility where the individual is being held. And when we look at information that we receive as collateral from those facilities, malingerers are more likely to have reports of being, verbally or physically assaultive, maybe having sexual relationships with female staff members, dealing drugs, or being considered a flight risk from the forensic hospital setting. They may tell kind of this far-fetched story, all kind of in an effort to retrofit the facts of the crime into their insanity defense narrative. Um, and lastly, in any case where the individual has a partner. So a person of normal intelligence is pretty unlikely to go along with a plan that sounds psychotic. So I've got two cases that come to mind to kind of illustrate this point. The first involved a young man with a long documented history of schizophrenia. And he had a very brief window of stability. And of course, in that brief window of stability, he was able to enlist in the army. Never a good thing. Um, he serves in the army briefly, and he eventually gets charged with efforts to solicit others to help him commit murder. Um, so he believed his delusion was that his parents were in cahoots with the army to sell him into the army to be used as an organ farm. And now they were kind of in cahoots with his commanding officer to make good on the sale, so to speak. Um, so one evening, he's out for drinks and dinner with some other members of his unit. And this soldier explains what's happening to him. Yeah, my parents sold me to the army. They sold me to Captain so-and-so. They're planning to use me as an organ farm. This is all coming to fruition. Can you guys help me, take them out? I want your help. I have this elaborate plan to kill our commander and also kill my parents, and I would love for you guys to help me with that. So these fellow soldiers, they say he seems pretty unwell. And so they quickly reported that incident because he seemed unwell and they were of average or above average intelligence. And they said, we're not going along with this. That sounds crazy. Conversely, I had a case where a woman was charged with killing two of her four children. And at the time, she had a roommate that she was able to convince not only to help her kill the kids, but also take the fall for her. We ultimately diagnosed the mother as antisocial, narcissistic, and borderline personality traits. But the roommate was also evaluated and was diagnosed with both an intellectual disability and a psychotic illness. And those two things in combination really rendered her, kind of exquisitely vulnerable. To the manipulation by the mom. Okay. So, next, take a quick look at specifically malingered psychosis when it comes to pleading insanity. So, quick background on insanity pleas for anyone who's not familiar. An insanity plea falls into the category of what we call affirmative defenses, also known as the I did it but defenses. Some other examples would be like self-defense or entrapment. But in the case of insanity, what the person is saying is, I did the crime, but at the time I was so out of my mind that I either didn't know what I was doing at all, or that I didn't know that what I was doing was wrong. So you can see how claiming to have been psychotic at the time of the alleged offense would be pretty wildly helpful here. So some things that we can look for to tease this out further would include a non-psychotic alternative motive for the crime. Again, things like revenge, jealousy, greed, or anger. We'd be on the lookout for suspect delusions or hallucinations. We'd be looking to see if the current offense matches a past pattern of criminal behavior. Is the accused displaying negative symptoms? Their absence would make me pretty skeptical. If the individual is reporting that the crime took place because of a sudden onset impulse that was just entirely irresistible to them. If the defendant claims, what we'll call double denial. I didn't do it, but if I did do it, I was probably crazy. If they're alleging illness that is inconsistent with their known and documented level of functioning, if they're alleging an intellectual disability on top of psychosis, especially without evidence of that disability being previously documented, or again, the presence of some kind of partner in crime. People who are thinking clearly, again, don't usually get involved in the crimes of people who appear to be out of their minds. Okay. Second to last thing I wanted to touch on, because I know we're running out of time, is diagnosing malingering in a correctional setting. And the actual rate of malingering amongst inmates is not so clear. Some studies done in medium security settings show a rate of about 32%. So to these inmates, sometimes the exaggeration of symptoms is a means to secure necessary or desired treatment. So while still in the realm of secondary gain, it's not quite the same as what we've been talking about. We have to be judicious in our diagnosing malingering in this population because, as we mentioned before, the diagnosis can be stigmatizing. It can impact future care and treatment. And we see that exponentially more in this specific population, specifically in those who have genuine mental illness. And they just kind of up the ante a bit to ensure that they receive treatment that they need. And there are some cases where an inmate will be serving their sentence without issue. And as they approach release, they actually begin to feign psychiatric symptoms. It's often believed, that might help further disability claims as they exit the prison system, but can also speak to kind of the security that they have found in a life of institutionalization. All this to say that an inmate who may choose to malinger a symptom or two does not effectively rule out genuine mental illness. Okay. So, there are times when we should be cautious about diagnosing malingering in a correctional population, and I've outlined some of those here. So if you have trouble identifying a clear motivation to fabricate, if you know there's been an extensive psychiatric treatment history, if the inmate did not self-refer, meaning someone else was really concerned about them, if they present as defensive, minimizing their illness or symptoms, or if they oppose treatment. If they accept medications and show improvement on them, or if they do, better when they're removed from Gen Pop and moved to a mental health unit. If there's concomitant history of intellectual disability or TBI, or if they frequently require increased levels of observation, or if they demonstrate a higher number of objective suicide risk factors. All right, and the last thing I wanted to touch on, because it's basically the opposite of malingering, is defensiveness and denial of psychiatric symptoms when they are indeed present. So we use the word defensiveness to describe someone who strives for positive impression management by minimizing the presence or impact of psychological symptoms with the aim of basically demonstrating perfect psychological health. So we just spent this entire evening talking about why someone would fake bad, so to speak, but why might someone fake good? Typically, that's going to be, again, to avoid the stigma that a label of a mental health diagnosis can bring. And the most famous example I can typically think of is Ted Kaczynski, or the Unabomber. Some suggested that he had a formal diagnosis of paranoid schizophrenia. But whenever the idea of an insanity defense was suggested by his legal team, he would refuse to engage in that strategy. He was pretty openly against asserting an insanity defense because he believed that having a mental illness would damage his credibility with regard to his kind of anti-technology based manifestos that he produced. All right. So we've reached the end. Sorry, I talk pretty fast. That is all I've got for you. Wanted to thank you for coming. I will stop sharing and pop my face back on and open things up for any questions.
First of all, I want to thank you. That was incredible. Yeah, does anyone have any questions?
I had a quick question. Thank you so much. That was amazing and so helpful. I'm doing my placement at inpatient psych at Tucker Pavilion, and you had mentioned, sometimes with psychotic symptoms, not expecting them to see them resolve, say within a couple days or like improve. And I was wondering if that's ever different if someone has been on antipsychotic meds, but has maybe been non-adherent for like a couple weeks or a month. Do you expect to see a faster resolution?
Yes, for sure. So we would expect to see a faster resolution, and yeah, maybe someone who just been more recently not adherent with their medications, getting them back on their meds, getting those doses titrated up. We may for sure see faster resolution. We would also hope that hopefully they didn't completely relapse to their worst of their worst presentations in that interim period. And the other time that we would expect pretty rapid resolution is if the psychosis is substance induced, because typically the only treatment for that is going to be stop using the drug that made you psychotic. So we'll bring folks in, allow them to metabolize, and hope that the symptoms get better. And sometimes those folks do need the initiation of a low dose antipsychotic medication, but oftentimes they get better just by, no more drugs. But yeah, we would expect to see that resolve a little bit faster.
Awesome. Thank you.
Is there any other questions?
Yes, I had a question. So in the ICU, we see people fake a lot of medical conditions and they get referred to psych. So are you saying that the malingering is more of a behavioral issue? Is not really, there's no diagnosis associated with it. How do you treat them once they're referred to psych if they fake a condition to, or they fake any diagnosis to get hospitalized? How do you assess the risk and treat it? Do you worry about getting sued later on with their diagnosis at that point? Like, are they safe to be discharged?
I mean, so
That's a
that's
lot.
when that's when
Mhm,
that's when past records are your best friend,
mhm,
or even
mhm,
contradictions in a patient's
mhm,
story, right? Um,
mhm,
the other day I had a patient on the inpatient unit who we were proceeding with discharge with. We believed he was demonstrating conditional suicidal ideation.
mhm,
He was pretty recently homeless. He had relocated from North Carolina to Richmond to live with his sister. His sister did not want to put up with his drug use and his shenanigans, and so she kicked him out.
mhm,
So he's here in
mhm,
Richmond. He's got nothing but a car and the clothes on his back. And so he comes into RER and he says, I am so suicidal. Now, because he
mhm,
came from an outside health system, we had no paper trail to go on. And
mhm,
so kind of common sense says, well, we bring him in, we observe him, we see what's up.
mhm,
So
mhm,
in the course of an interview on the day of his discharge, he's like, in one breath, he's like, "Hey, can the social worker help me finish up my Medicaid application?" Which is kind of evidence of very forward thinking. If you are planning to
mhm,
be dead in the next 24 hours, why the heck do you give a crap about your Medicaid application?
mhm,
He
mhm,
also referenced kind of he'd been trying to get into a long-term residential substance treatment program prior to him coming to the hospital, and he asked about the status of that. So again,
mhm,
something that would be very strange for you to be concerned about. But also in the same
mhm,
breath, he's like, if this window didn't have a screen in it, I'd be jumping out of it right now.
mhm,
So we look for kind of those internal inconsistencies. We look for
mhm,
inconsistencies, within the medical records that we have available to us. And we use all of that to kind of hopefully mitigate our risk. And when we look at literature, specifically on things like conditional suicidal ideation in the emergency department, do we admit someone who's saying that they have suicidal ideation that's purely conditional, like if you let me out of this ER, I'm absolutely going to kill myself, and it's going to be your fault, and it's going to be on your conscience. Well, the
mhm,
literature that we have that studies that subject exclusively says that at 7 years out from those conditional suicidal ideation statements, exactly 0% of patients have gone on to harm themselves. So the literature's
mhm.
on our side in some of those
Okay.
situations.
Yeah, I'm just worried about like how safe is it? It seems very risky to say
I
someone
mean,
is faking something. It's scary. Hmm. Okay. Okay. How do I get that?
Thank you, Robin, for your
You're
question.
welcome.
Thank you, everyone. Is any other questions?
I have a quick question. I do diagnostic assessments to determine eligibility for a behavioral health docket, so sort of in the forensic setting. And you mentioned earlier the SIRS was your favorite assessment tool to detect malingering. I just wanted to make sure that that was applicable, just as applicable, sorry, in the forensic setting as it was in any other clinical setting.
Yeah, so typically in a clinical setting, I wouldn't reach for the SIRS because it takes about 90 minutes to administer. The faster option in the clinical setting would be the test called the MFAST. It's not quite as sensitive and specific or in depth as the SIRS, mostly because it takes about 10 minutes to administer versus about 90 minutes. But it's a good jumping off point if you are concerned about that. I would kind of think of it almost more as like a screening instrument. And if that pops hot, that would push me towards additional psychometric testing.
Okay, great. Thank you so much.
Uh, Dr. Chiarella, would you be comfortable with me sharing the slides that you provided? Or do you want to look through them and then decide? Do you want to let me know?
Fine.
Okay, cool. Yeah, so I have permission to share the slides. What I've learned is I don't blast them out to everyone. I like to send them out to those who attended. So if you are here right now, those of you, hi, and you'd like the slides, I need you to email me. So here's my email. And there it is. So I just want to send a huge thank you to Dr. Chiarella. I mean, your expertise speaks volumes. This was an absolutely incredible continuing ed session tonight. I learned so much sitting here. I think we all did. So thank you so much. And you know, you had people stay past the time, so that is reflective enough. So thank you. And thank you all for being here tonight. Make sure you fill out the attendance sheet, and hopefully we'll see you in 2 weeks. I'm already getting emails for your slides. So that's
Sure.
impressive. All right. Thank you everyone for being here.
Thank you.
Yeah.